It is in live discussions. Free on-demand Pioneer playback service. Watch our webinars again and again in your own time. And coming soon, our new bespoke learning management system will host podcasts, an online version of the famous SICOT diploma exam, virtual training modules, surgical technique courses, a discussion forum, and much, much more. We hope you'll join us on this pioneering journey as we push the boundaries of what is possible in online orthopedic education together.
Good morning, good afternoon, and good evening, ladies and gentlemen. Welcome to the SICOT Pioneer webinar series. I'm Dr. Margaret Fogg from Hong Kong, the SICOT Education Academy Chair, although I'm in Scotland now. But before introducing today's chair and faculty, I would like to share some background of the SICOT Pioneer initiative. SICOT Pioneer is part of the SICOT Education virtual platform, which launched in June 2020. Since its inception, we have done over 114 webinars and 7 tete-a-tete sessions. To date, the platform has garnered over 50,000 live views and just over 93,000 on-demand views. We're also proud to have a Pioneer fan club of over 11,000 members. If you would like to explore over the previous webinars and other education activities, please visit the SICOT website at www.sicot.org. We also encourage you to join as a member to access these resources on demand. Today's webinar is actually the first webinar that is done by our SICOT Digital and AI Committee. It is collaborated with BOSTAA, which is a British Orthopaedic Sports Trauma and Arthroscopy Association. The topic is about AI pioneered powered orthopedics from date to decisions. Our moderators are Imam from UK, who is actually a BOSTAA EC member, as well as Dr. Suresh, who is our chair of the SICOT Digital Orthopaedics and AI Committee, as well as the treasurer of SICOT. So without further ado, I'll hand over now to our moderators, Suresh and Imam. Enjoy.
Good morning, good afternoon, good evening to everyone. Welcome to the very first SICOT AI and Digital Orthopedics webinar in collaboration with BOSTAA. So I'm going to start off with my dear friend, Professor Mohamed Imam from East London, and he is going to talk to us today about multimodal, large language, and medical models in everyday orthopedics. Take it away, Professor Imam.
Thank you. Thank you very much, Suresh. It's a pleasure to be here with everyone, and I'm very excited to be part of this great webinar, and hopefully you'll have a lot of fun and a lot of ideas that you can take to your next to Monday's practice. So this is actually my disclosures, which is not directly related to that, but I'm a professor of digital health in London, and I lead the Smart Health Center, as well as the director of research National St. Peter's. We do a lot of digital health and a lot of AI related research. So it is important to think about the multimodal aspects, because AI has been around from late 50s when Professor McCarthy has popularized the concept of artificial intelligence. So it's not out with ChatGPT. It has been there for a long time. And initially, we have unimodal systems, which is you put text, you get text out. But actually, as physicians, as physiotherapists, as anyone in healthcare, we do multimodal in our decisions. You look at the patient, you look at the scans, you hear the patient, you look at the, you know, if you smell cigarettes, that might change your decision. If someone come drunk to the clinic, that might change your decision. And that's what we do, the multimodal aspects. So I'll start with this number, 184. So these are this is one of the early studies in multimodal AI, and this in the authors looked at 1,136 consecutive emergency radiographs.
Imam, sorry, I think you need to
yes.
put it in the screen, the viewer mode.
The what?
You slide
is at the
yes. That's what I have. Do I have to put it in presenter mode? Oh yeah, I thought that's what I had. Sorry. And here, yes.
Not yet. You need to click the.
Try the slideshow. Yes.
Yeah. Great.
Okay, so nearly one in three of everything it has cleared. So in this talk, it's the next 10 minutes, I'm going to talk about 3 families, 3 jobs, and 1 rule. We'll talk about what is AI. I think, no clinician or actually a person on earth can live without AI. You can live without AI, but you will lose a lot because AI can add a lot of IQ points to anyone in any specialty. So first, and then we will talk about 3 jobs and 1 rule, which you can apply tomorrow. So there are 3 animals in AI, 3 different animals. There is a narrow model, which you put 1 task and get 1 input. And that has been the dominating AI model since Alan Turing in World War II popularized the concept of AI. And obviously large language models, which text in, text out, and that has been the game changer in AI business, where made it mainstream. And then the multimodal model, which behaves the way we behave in clinic. It is a bit shallow, so that the system can read images, can listen to voices, and can read text. So one system takes a radiograph, reads a letter, checks the bloods, and it is broader. So that's the hot topic of this talk. So the main change here wasn't accuracy. It is mainly the context. Because, as I said, we diagnose and treat patients based on so many variables. Actually, if you have a room full of 100 orthopedic surgeons, you will hear different aspects that made them decide what to do for these patients. And actually, it's not only the X-ray, it's definitely not the MRI, but it is all of them together. And the issue with multimodal so far, although it is happening and it is gaining popularity, but it isn't the same as competent, because remember that figure I've shown you, the 184 one, it was very accurate when it was related to knee X-rays, but it is almost useless when it is related to ankle and foot X-rays. So we cannot treat as yet to be a great tool to what we do. Because 82% of missed fractures were not displaced, subtle on the film and visible retrospect, which always the case. And 17% of missed fractures in this study went on to need an operation. And so most commonly missed among those needing surgery was pediatric supracondylar fractures of the humerus, as well as adult femoral neck fractures. And every orthopedic surgeon in this webinar understand how serious can it be to miss these injuries. So the systems we had, wasn't accurate enough to be able to use on our day-to-day practice, at least at this time point. Maybe when we do this webinar, June 2027, we'll have shiny green figures then. And the issue with AI, and that's actually the issue with large language models, because people, we've just finished writing a book on AI literate patients. I think that's what people misunderstand about artificial intelligence. It's not all the same, and it depends on how you train the models. So a model with no dedicated fracture training reads a film like a medical student attending your clinic for the first time in their life. So we cannot have complete confidence in them. So what are the three joints the AI does well? There are few things and a lot of projects happening. So before the clinic triage and assessing the referrals, there are a lot of systems which we are currently utilizing, which is helping, and a lot of development happening there. So that can save the admin time. And as we know, in the current environment, the only limited resource we have is time, and it will always be the case. And then in the clinic, for the last few years, I would use ambient voice technology where AI can actually listen to my conversation with the patient, create a letter, and I can create that letter, and that will create the letter in no time, saving a lot of time there. We developed a project which is called Consent IQ, which would actually, the AI, which is part of the Ortho Globe, which is not for profit organization that I was happily co-founding it. And we, the patient, will actually, with these systems, that will create a link to the relevant consent form on the website without any interference from me. So letter is done in seconds based on my consultation with the patient, include evidence, and the model is trained to create the letter based on evidence, and more importantly, can be tailored to be trained based on your experience there. And then after the clinic, you can check guidance and so. So one of the projects we've done was resbot.ai, so that actually can do a structured literature retrieval, properly trained over thousands of meta-analysis. It can actually, a meta-analysis that can take a resident a year to undertake, now can take 6 hours to do it properly. I'm not talking about a random literature research. It is actually done properly using the Prisma and other guidance that would be suitable. One of the other things which we've done also is the Ortho Prep, which is part of orthoglobe.org. And actually, we have a database of questions which is relevant to board and FRCS questions, and all what the candidate would do is they would actually start answering questions, and the AI model in the background will identify points of weakness and will guide them to do more of these questions so that they get ready to the exam. So it's not perfect yet, but there are a lot of achievements that we can undertake, and there are a lot of work happening everywhere in these fields. And actually, ambient scripts is actually mainstream now, and there are a lot of models. You can even train ChatGPT extension specifically tailored for you to undertake it for you, and a lot can be done. So I have 3 questions in being director of research in a couple of big institutions and being involved in that. Before a model touches or meets a patient, there are 3 questions that we have to answer. It's not all shiny and it's not all great news. So what can it see? What was it trained on, and who carries the risk? And I think point 3, I was attending AI meetings 10 years ago, and there were talks about jobs being lost in medicine, like pathologists, radiologists, and so. But today, you still take the risk, you still take the responsibility. That you cannot blame a machine, you cannot blame a humanoid when a vessel is injured, or a humanoid report when a vessel is injured. So there has to be a human as well involved in that. And that's why our jobs will be safe, at least for a period of time, despite what Elon Musk is saying. And there is always one rule, and that is the only thing I'd like you to take home with you. Use it where being wronged is cheap and checkable. Drafting the clinic letter, I always read it, even that I'm using ambient voice technology for years now. If there is a referral, I have to make sure it is mine. I have to check the citations even in a model that we spend 6 months training to produce meta-analysis. And always, it's your responsibility, whatever is happening. And why I say it's cheap? Because clearing a supracondylar fin based on a model like what we've seen, and that child will have the rest of their lives with limitations because of one mistake, this is a very expensive error. And we have to make sure we are there and have due diligence whenever you're using one of these. So the 3 families is important to understand. There are 3 jobs that we are doing so far, and the one rule definitely need to do it. And also, if you're attending the SICOT meeting in Kyoto, we have an excellent session full of experts talking about different aspects on that day. Looking forward to seeing you all on that day. Thank you.
Thank you. Thank you very much, Professor Imam. I have, if you have any questions, you can send it to the chat and we will ask the speakers. So please don't hesitate to send any questions in. We don't have any pressing questions at present time, so we can always save it for the next one. So after this, I will be introducing Professor Amanda Isaac, who is here on behalf of BOSTAA. So she's going to talk to us about smart scans and sharp eyes, AI in orthopedic diagnostics. Welcome, Professor Amanda Isaac. Thank you very much.
Hi, are you able to see my screen?
Yes.
Yes, we can see your screen. Absolutely.
Thank you. Thank you for the kind invite. I don't have any conflict of interest relevant to this talk. I'm just involved in a lot of AI organizations and initiatives. The rationale of involving and trying AI in MSK pathologies is that perhaps it's one of the commonest presentations to healthcare establishments with a huge workload on all institutions, but also we tend to utilize a lot of imaging modalities that create large data sets. These therefore present a more significant workload to most radiology departments compared to simpler scans that can be reported perhaps faster in a different workflow. We also have a huge potential with opportunistic screening, and I'll come to that, where MSK in particular is proving to be successful. Furthermore, there is an expanding role of providing minimally invasive MSK interventions under image guidance, where AI can really play a role in these outcomes. So the current role of AI in MSK is not just on one side. If you look at here, I think that's a very simplistic and easy way to see it. There are things that the patient can see that we're and can understand that we're including AI in. And then there's stuff in the background that the doctors use that perhaps is not visual to the patients. And with these, the patients may not be even aware or consented to be using AI in their care. This is important because with all the ones that we have a patient-focused solutions, we need to involve the patients and the patient advocates to really engage with us so that we're able to implement these. The first rule is creating faster, higher quality images for radiologists to be able to read more efficiently and therefore to be able to issue these reports to you so you can provide faster care for your patients. One of the biggest achievements is metal artifacts. And as you can see here with CT, standard images always have these blooming artifacts, and we put more and more metalwork in patients. So this is particularly relevant now, where we can have these crisp images, get rid of the artifacts without affecting the quality of the soft tissues underneath. So we're not manipulating the images and we're not changing what it is, the pathology that it is underneath that we need to see. This is particularly important when we're looking for any metalwork failure, periprosthetic loosening, periprosthetic fractures, or tumor recurrence in case of fixation due to the presence of malignancy. It's particularly important now with being able to provide low field imaging. So these are scans of 3 Tesla, which everybody thinks is the magic wand, the 1.5, which is our standard imaging in most departments, and then the new low field MRI, which is the 0.55 Tesla. You can see that metal is significantly affects images with the 3 Tesla. So the higher the magnetic field, the lower the quality of the images. But with the 0.55, you get rid of a lot of the artifacts. It's less susceptible to it. But also we can use post-processing to get rid of the artifacts so that we're seeing the pathology a lot clearer and we're able to see what is going on underneath. This is an example with the 3 Tesla comparing to the 0.55 with a patient that had a post-operative hematoma. And you can see the entire spinal canal, you can see the pathology, and you can quantify the extent of the abnormality. Whereas with the 3 Tesla, you can't see anything. So the report says we can't see anything. You can also use it for tomosynthesis so that we combine the benefits of having plain films with higher spatial resolution with the benefits of the cross-sectional imaging and the higher bone metal interface with CT. So we provide these images with lower radiation doses than conventional CT, but then you get the benefits of having all the wonderful things that we like to rely on in X-ray, particularly, again, if we're looking at bone tumors, abnormalities in the texture of the bone, or anything with the bone metal interface. You can see it here again, and you can see the extensive loosening, whereas with CT, it can be a little bit fuzzy. With the digital tomosynthesis, you're seeing and quantifying how much of that abnormality is there. This is an example with 3D imaging. So now we have faster acquisitions that we're able to do 3D volumetric acquisitions, similar to what we do with CT, but we can also amplify and speed it up so that these are 4 or 5 minute acquisitions for the entire volume of the whole spine. And then we can manipulate it so that you can do MPR, same as you do with a normal CT. And then you can also angle it so that we're seeing the dorsal root ganglia a lot more clearer. And we use that to be able to quantify and assess dorsal root ganglia with size, volume, signal, and use all the benefits that we get from the information from MRI to be able to do better neuromodulation planning. As you know, MRI neuromodulators are very expensive. They're about 30 grand per patient. So we need to be confirming the levels affected, how much of it is affected, and where the location of the dorsal root ganglia to be able to offer and optimize the treatment. We can also do post-processing imaging. So this is an example of something that is new, where we use volumetric rendering, VR, with the same benefits, but you can manipulate it with light and shadow to be able to do 3D assessments. So volume rendering with cinematic rendering basically allows you to go through the whole volume of a lesion. So this is a peripheral nerve sheath tumor using MRI, so you don't have to do CT to get that information. And then you can also do the slicing where you can see the matrix and the extent of necrosis within the peripheral nerve sheath tumor. So this is what you see when you open as a surgeon to operate, and this is what the matrix looks like. And you can explain to the patient what it is that you're doing, why you're doing what you're doing, and it helps with consent and also helps with teaching when you're offering education to your trainees. This is another also wonderful example where education with images play a role. So this is a patient with prepatellar bursitis. You can't diagnose it in MRI because this is how we're trained to read scans. But when you offer cinematic rendering, you're able to demonstrate how much neoangiogenesis there is, how much of the lymphatic inflammation that we're picking up. And that perhaps helps the trainees and the patients, if we're offering intervention, understand why they have so much pain. They wouldn't understand this based on these images. It's a steeper learning curve for them to appreciate that. But when you show them these scans, you really improve the quality of the information they're getting and forming. One of the really exciting things is being able to offer ionizing radiation low-dose imaging. And historically, we didn't like doing these because it's grainy, you get less information, but the information is there. So then you apply CNNs, convolution neural networks, to denoise the images so that they look like the nice crisp scans that we do if we use higher radiation doses. That's particularly useful because you can see better images with up to 25% lower radiation, but also you can use lower contrast volumes. So that's particularly important if you're using it for patients with renal failure, for instance. And we can use that for intervention. So we use that now to do something called low dose fluoroscopy when we're doing interventions where we really need to be able to see the information. You can also do it with simulation and procedural modeling. So we run the procedure in real life as a practice with radiation dose optimization. And therefore, you can run it several times before you actually do it on the patient to reduce the radiation dose. That's particularly important now that we do a lot more volume of percutaneous procedures, and we have a steeper learning curve that we don't need to go through as much radiation. So historically, interventional radiologists had to be given a gardening leave because their radiation doses are building up. So they're giving a holiday to relieve them from the radiation exposures, which meant that they did fewer scan procedures per year. We don't really need to do that anymore, and we're able to offer more procedures for patients safely. And this offers an opportunity to alter the interventional procedures as a patient care basis. So you're optimizing on the volume and the size of the patient, but also the interventionist. We also do synthetic sequences, and this is a developing field. It's not yet used in clinical practice, but you can do MRI images from CT or CT images that look like CT, but they're originally MRI. And that's particularly useful if we want to use the benefits of having CT images or MRI images, so soft tissue and bone. We use the derive images like these, where you're using it to analyze on a level basis, on a texture basis, and a cortical basis. And that's really important when we have tumors, if we have a lot of complex dysplasia or complex post-operative with a lot of revisions where the anatomy is distorted. So that helps us plan a lot better patients. And this is out there. It's already in clinical practice. Perhaps a lot of you know the EOS machine, which is basically radiographs created by X-rays. And then we have CT-like reconstructions. You can use it with weight bearing. So it allows us to get all the information of dynamic imaging with weight bearing. And then we have CT-like images, so we plan the procedures better, and we do all the lovely measurements that help us plan and optimize per patient with precision. I'll go quickly through the measurements and analyze. So we're able to derive mechanical information, and I think that will be a key thing working together with orthopedic surgeons to be able to optimize interventions and implants, and that will play a big role in the custom implants and how we take the current implants to the next level. We can also do it with sitting and standing alignments. We can do labeling, and this is an important thing that is now playing a big role with medical legal. So we know that we misdiagnose the lumbosacral junction. There was a survey by the British Spine Society, and that confirmed that up to 50% operated on the wrong level, 40% of which was at L4-5, and 47% of these patients needed a second surgery. And that's because of the way the patient is aligned on the prone for surgery compared to the images that we have. So we can integrate this information now with objective optimization and integrate it into the robots when you're doing robotic surgery, as well as help us have a check. So it's not telling you which level to do, but it's allowing you to have another layer of checking before you operate. Similarly with diagnosis and fracture detections, because we're able to do the segmentation and anomalies, we can run it in the background and do a lot of opportunistic scanning and imaging. And then we're able to do opportunistic osteoporosis screening, which is a big thing now because we know that the patients have a higher incidence of other consequences if they have osteoporosis, like implant failures and fractures. But then we also know that these are treatable conditions that we can improve for the patients. There is a lot of evidence that we can do this efficiently with AI. And this is an example of software that is able to label and analyze the images. So then we're able to do this in the background and issue a report. With that, the Royal College has issued guidelines that we have to include opportunistic reporting for any patient that has CT chest abdo pelvis, and we have to report these, and there is a huge role for AI with that. To basically summarize, there's a lot of potential for these patients to have better outcomes, to be able to offer better services for patients with AI, and to work together to improve the outcomes for the patients that we have and develop new technologies. Thank you.
Thank you. Thank you, Dr. Isaac. A couple of questions. In your hospital, are you using any commercial software to analyze these images, or are these all in-house?
Both, a combination. So I'm lucky to be working in King's College London, which is a big department with AI, medical AI. And then so we use and validate software that comes through the AI Center for Healthcare. And then we're developing our own in-house solutions as well.
So how does it work? Say a company comes to you, and how do you evaluate it? And what about, GDPR and privacy? So do they just put their server in there and it's all anonymized? Or could you advise us on how to work with such companies?
Basically, we have infrastructure that allows us to do something called federated learning. So the information and the patient data does not leave the hospital. And then we're able to plug things externally to the AI center. And then the AI center is the barrier between both. So the companies don't get any information. We give them the analysis. We collect the information, not on a patient level. We give them the performance on the whole set. And in the hospital, we work with the experts, so the chest experts, the bone experts, whatever the software is able to do, so that you have the clinical validation internally.
Hey, wonderful. Just a question for all the panel from the audience. As an orthopedist interested in AI, I've taken a number of courses and also as a trainer. How can I join the orthopedic community interested in AI? And is there a chance to do research? I guess the answer would be for you to join the Digital AI Committee of SICOT. What do the others think?
I agree, Suresh. I think there is a lot of interest nowadays in AI in everyone with different levels. There are, for research, I think it's good, like what I've mentioned, also Globe, also SICOT Research Academies. There are a lot of collaborative work happening now. And, the first is definitely the committees, as you said, like SICOT, SICOS, CEST, all international or have technology or AI working groups, and they take applications from members. So you have to join SICOT first for that. And the second is collaboratives, as I said, multi-center studies, recruiting site leads. That's definitely good. And the third one is the bottleneck in orthopedic AI is not people who can build models. It is labeled clinical data and clinician who can stay whether the output is meaningful. And as Amanda has mentioned, federated learning made international multicentric studies more doable than before. So my one warning is do not start by looking for a project. Start with a question from your own clinic that bothers you and the data you already have, and then search for the projects that begins with an algorithm and go looking for that, definitely.
Thank you. Thank you, Mo. So what I'm going to do now is hand over to my co-moderator, Professor Imam, to introduce the next three speakers. Okay, take it away, Mo.
Thank you, Suresh. Thank you very much. So the next one is actually Professor Khaled Emara, joining us from Cairo, Egypt, and his talk is how to use AI in your clinical practice. Up to you, Dr. Emara.
Thank you. Can I share my slides? Yeah. Okay. Can you see my screen?
Not yet.
Now, yes.
Yes, yeah.
Okay, good. So basically, what my task is how to use AI in your clinical practice, on everyday practice. So my talk will be a little bit more simple. So I will talk about using AI in your daily life in 3 pillars and as an AI agent. And when I'm talking about an AI agent, like someone who is your secretary, your junior resident, your assistant, but not your replacement. Second is patient assessment. Third is doctor assisting. So pillar 1, as an AI agent, basically you can create an AI agent that receives patient questions and then analyze it according to the NLP, then search the knowledge base, generate safe response, and deliver the response and keep privacy. In my practice, my daily practice, we used the N8N website. We used the retrieval augmented generation vector, and we used Telegram as a bot for communication between our office and the patient. And this is the diagram of our working flow. So for a very long time, I had a social media page that translates English scientific literature to our language in our region in the Middle East, which is Arabic. We took this data. We also used the publications, my international publications, and we used this data as a reference for our AI agent to answer the patient. So the patient send us an answer, a question on Telegram, and the AI agent get the answer from a specific reference that we defined it for it from the early beginning, which is what if Dr. Khaled answered this question, what he will say. And as you already know, there are 2 kinds of AI now. There is a closed source and open source. And in the future, open source will be very helpful for all of us because now you can even buy a GPU unit that in your hospital ranging from $3,000 to $400,000. So even people who are worried about leaking patient information to the big companies like OpenAI or Anthropic or etc., you can use the open source on your unit at your hospital and keeping the data for the hospital for the patient without the risk of jeopardizing the patient confidentiality. But also, even in closed source, you can also keep the confidentiality of your patient. How we do that? As I was saying, the AI assistant or the agent gets structured educational database and give automated out workflow and reliable method. And we defined for my AI agent, but it's up to you, we defined 15 minutes as a memory. So after 15 minutes, everything is gone. But the memory is up to you. You can decide how long the memory is. And as I was saying, we're using Telegram because it is easy, but you can use any kind of communication, including WhatsApp or whatever you prefer for your patient communication with you. So the second pillar is patient assessment. And I will try to give you some real life examples of how to use patient assessment, AI in patient assessment tomorrow. So for example, in triage and history taking, there is an application which is Symptom Checker or Informatica. That's very helpful regarding image analysis, one view, regarding risk scoring. For example, you put the data of the patient to know what is the chance of exposure to this kind of complication or that kind of complication, etc. That's, for example, You can use Potter. In gait analysis, you don't need to send the patient to a gait lab now. You can just need to use cameras, either one plane or two planes or three planes, and the program is already able to analyze the three dimensionals, this program called OpenCap. All these are available. Some of them are paid, of course, but I mean, you can use it tomorrow on your phone or on your computer. And we already heard the talk showed us that the accuracy and the sensitivity and specificity of AI in reading images and finding X-rays and fractures. Regarding the post-operative AI monitoring and rehab, for example, remote patient monitoring, the BioFormis, it's a very useful tool for following these patients. We use the smartwatches and stuff like that, but this AI program, it's not only telling us about how many steps the patient walked, but it analyzes the information and give us relevant conclusion from it. Regarding AI-guided rehabilitation, SWORD is a very useful program that helps patients and modify the rehabilitation program for total hip and total knee according to the patient development and patient need. Regarding digital twin technology, it's very helpful now. You create a digital twin for the patient, and that will make you able to predict what are the possible outcome. A patient with diabetes, for example, or old age, or any kind of comorbidity. So this digital twin will tell you when this fracture will heal, or what is the chance of getting into non-union or infection, stuff like that. Outcome scoring track, My Mobility is also a very helpful tool. You can use it. We count on virtual assessment. We get many consultations online. And actually, we published a book a couple of years ago about principles of virtual orthopedic assessment, how to assess the patient on remote. And it's a developing field. It started with COVID in 2020, but now it is booming that everywhere we get consultations online. So you need to be able to assess the patient remotely, not only in your office. The third pillar is assisting the doctor. What the doctors need: surgical simulation and virtual reality and visual augmentation that will help us in the field of surgery. Big deal, because it will help us to magnify things that we would like to see and augment the reality, and also in training. Adaptive learning platforms. There are several adaptive learning platforms nowadays. AI case generation and multiple choice questions. That's also, you already know about it. You can even go to ChatGPT or Gemini or whatever. That's a very simple thing. Everybody do it today. Surgical video analysis, that in trainees, you put the camera on your head during your surgery, and then you take the video, the recording, and give it to the AI to analyze and get a feedback about what the steps you did during surgery and what you did right and what you need to improve. Also in literature synthesis. Nowadays, you don't just go to PubMed and collect this 100 papers and read these 100 papers. AI can help you in analyzing and synthesizing this literature and summarize it to you. But as Dr. Imam emphasized, you need to look after your assistant. You don't need to rely 100% on your assistant, on your AI assistant. Another thing is research assistance. In people like me, we are not native English talking or speaking people, but we need to publish our scientific research in English written journals. So if you have an AI model that can review your English and the language, that's a great advantage on your side. So for example, for ambient documentation, DeepScript is a very useful thing that can do the documentation and dictation instead of wasting your time in the electronic medical records. clinical decision support, like open evidence that help you a lot, surgical planning, like Medicad, that you can plan for your osteotomy and for correction of the deformity, and it is very, very good and very effective and accurate. So we need to remember that use AI as a tool, protect patient privacy, disclose that you are using AI, always review AI outputs, and don't rely blindly on the output. Don't replace examination. Don't ignore bias. It's very important. Even after very reliable report, you will find between lines that there are some bias and some mistakes. Use public AI for identifiable data. Regarding intraoperative, now you already know about robotic arms, guidance, like Mako and stuff like that. From Stryker, it's all now AI augmented. Regarding real-time alignment verification during surgery, like Preoperative. At the end, I would like to remind you that evidence-based medicine does not only depend on the best available clinical evidence, but also depend on the patient need and what's available in your hand. So best available evidence need to go hand in hand with the patient need and patient values, not only on the best available evidence. And as we already know, in any kind of technology, once the innovation starts, there is huge enthusiasm and people get very excited about this new technology, and it gets to the peak. But then people start to get disappointed because some problems they expected the new technology will solve it, but they don't find it working. So some trough of disappointment happens, and then we reach the plateau where we get the wisdom that this new technology can help in something, but it does not help in something else. And in any innovation, there is early adopter, and there is moderate, like majority early or majority late, and there is the late adopter, the people who reach too late. It's better to reach in the proper time, in the going up curve, not at the late or late end of the technology. At the end, I would like to tell you that my talk today may be not valid tomorrow or even in few weeks. Field of AI is developing very fast. For example, this paper, it was published in June 2026. It was accepted 4 months before. So by the time this paper got accepted, which was comparing Gemini with ChatGPT, with the other large language models about accuracy of answering the patient question, by the time it was written, it was valid. By the time it was published, within 4 months, it was obsolete. So my talk today, maybe it will get obsolete within a couple of weeks or couple of months ago. So thank you very much for involving me in this great webinar, and I'm looking for your questions. Thank you.
Thank you very much, Dr. Emara. An excellent talk as always. So, what the one tool that you've used that you think changed your clinical practice significantly?
To be honest, the AI agent changed my practice completely. I'm an orthopedic surgeon. I don't want to waste my time in giving consultations that can someone else give it, or the patient can find it on Google, but the problem, he or she can find it on Google from an unreliable source. So instead of seeing 30 patients to do 6 or 8 surgeries, now I see 10 patients to do 6 or 8 surgeries. So that impacted my practice big time.
Okay, and I totally agree with that myself as well. And one another question from the other side: which tool you will be reluctant to use in your clinic as yet, based on what we have already? And I agree with what you've mentioned. Everything we give in this talk might not be valid in 6 months' time, but that's the accurate nature of AI. We just work hard and try to be quick enough. So, which tool?
I do pediatric orthopedics mainly, as you may already know. And gait analysis using OpenCap helped me a lot in patient assessment. So instead of waiting for the gait lab study and assessment, and maybe I disagree with them, stuff like that, that helped me a lot in my patient assessment instantaneously. So gait lab with gait analysis with OpenCap helped me a lot in daily practice.
Excellent. Thank you very much. I really enjoyed your talk. And so we cannot take more questions for the sake of time. Our next speaker is Dr. Chun Man Lawrence Lau, an orthopedic surgeon from China. Up to you, Lawrence.
Hello. Good evening, good morning, and good afternoon, and thank you for listening to the talk on the use of technology on modern orthopedic teaching. I'm Lawrence Lau from the Department of Orthopedic and Traumatology, University of Hong Kong, and I shall discuss how we are moving from see one, do one, teach one to technology-enabled personalized learning. So orthopedic teaching is uniquely suitable to technology because our field involves lots of complex anatomy, broad spectrum of knowledge from tribology to biology. It also involves multiple surgical skills that take years to master. So in the end, all these complex skill sets and knowledge have to be combined together to make high-stake decisions and actions. So here we see the technology map for modern orthopedic curriculum and some of the examples. For example, in the foundation course, 3D printing can be used to teach anatomy, and it can be also used to train surgical skill. Similarly, for the training of surgical skill, VR simulation, AR guidance, or robotics can be employed to assist junior surgeons to improve their surgical skills. And AI can also train medical students or surgeons in their reasoning and help them to develop a longitudinal profile. So we shall look into some of these examples in our subsequent slides. So 3D printing is useful in teaching anatomy for audience of different education levels and academic backgrounds. So in our department, we print 3D plastic resin models in 1:1 ratio for medical students so they can peel away the model and feel about the real anatomy in the real size. This is so much better than reading the anatomy textbook that's failed to replicate the spatial orientation of the human structure. And our departments also print models of different fracture patterns, and these models deriving from the real patients not only help our surgeons to plan the operations, but also help them to plan the implant positions. And after the operations, these models are recycled to teach the residents about common fracture patterns and used in training courses to teach junior surgeons on the AO classification as well. So our colleagues also 3D print patient-specific guides, surgical guides, and patient-specific implants. And together with the patient-specific 3D anatomy model, the surgeons can learn and practice to place the real implants numerous times before the actual surgery. So this whole process becomes a true personalized, self-directed orthopedic teaching and learning by the surgeons themselves. So in this recent paper from Singapore, it highlights a problem that while the current interest in 3D printing is high, overall the self-rated technological capacity was low. And near 76% respondent endorsed there is a need for formalized teaching. So if you are interested in 3D printing and its related education, you are welcome to read our articles published on the JLR and join our 3D printing course organized annually by our departments or follow our 3D printing fellowship director, Professor Fan, as shown in here. So other than 3D printing, robotic and navigations are commonly employed for orthopedic teaching. Here we shall illustrate how we use the Mako robots to teach junior on performing knee replacement. So as shown here, robotic planning can clearly visualize and digitalize the extreme deformity that the patient has and maybe failed to be appreciated by a junior resident. And you can see that the patient here has an extreme valgus deformity and excessive vacuotum. And with the safety boundary imposed by the robot, it allows me that to supervise the junior to execute the bone cut safely, as she will not be able to go out of the safety boundary and cut the vessels or the MCL. And with the robotic system, we can accurately measure the pre and postoperative alignment such that I can explain to the residents of what we have done to correct the alignment and how we can measure the degree of corrections and showing them what to be done to achieve this kind of corrections and provide a relevant debriefing after the operations. And this can also facilitate the post-operative care to the patients as well. However, not necessarily only expensive robots can do the trick. Affordable navigations can also serve the same purpose. As shown in this AR augmented reality navigation system, we can perform the operations with accurately measured alignment, so the juniors can perform this with a safety boundary and constraint as well. So, other than robotic navigations, virtual reality is also employed to facilitate teachings. So our school has pioneered several usage of virtual reality, and it can help illustrate anatomy as shown here and provide some spatial awareness and task training and also feedback to the students. And we have also used virtual reality to train medical students on performing bedside physical examination as well. And in some centers like the UCL, they also use the VR to train the trainee to do total hip replacement as shown by this paper. However, the downside of VR is the obvious lack of physical touch and tactile feedback. So that's why I would like to introduce you the digitally enhanced hands-on surgical training developed by the AO Research Institutes. So recently, I have visited the institutes as a ARI and APOA fellows and learned about this interesting tool. This training tool can combine the sawbone exercise with a virtual reality. For example, what's shown here is a minimal C-arm, and the residents can learn how to perform distal intramedullary layout interlocking screw. And as shown in here, this AO training tool can improve the performance of low-rise users and make them experience as practicing surgeons. So obviously, I teach medical students as well as junior surgeons. So in the past, we teach students in a face-to-face sessions. But nowadays, a large language model, as mentioned by multiple previous speakers, are very popular, but they may not be totally correct. So for example, in this photo that I generate from GPT is full of anatomy errors. So what I decided to do later is to make my own GPT to teach the student as shown here to ensure the correctness of the content. So we test the student on multiple occasions. So before a traditional teaching sessions and after before everything and after traditional lessons and after a LLM self-direct learning. And then I assess the student on their written examination and also with an OSCE type examination. So what we find that is an LLM GPT can further improve the performance of students after traditional teaching, but they may improve on the heart-fed recall with a higher marks on the written exam, but they do not perform much better in the OSCE type of exam. So that means that a supervised bedside and procedural practice is still in need in our current teaching curriculum. So we are even improving our system to not only allowing factual recall, but also engage in some active discussion with the students so that as if they were involving in some kind of viva examination. So we have discussed various aspects of technology in medical teaching. So these are the 5 core questions that I think that's important and we have to ask ourselves to achieve evidence-based implementation. And among them, I think the most important one would be the 5th one, which are what the cost, access, safety, and equity constraint to the technology. So although many technologies are lawful, but they may not be cost-effective to our education system. And it's discussed in all the slides mentioned before. Actually, human supervision is the core integrating part to achieve a safety usage of all this technology in education for the student. So with all this, I would like to end my talks here and remind you that in the end, expert teachers are still the most important keystone in our teaching, and together with an authentic patient case and validated technology, serve as an added value to our current teaching curriculum. So thank you very much for listening.
Thank you very much for this talk, which I think this is actually one of the commonest uses of AI that we have nowadays, and it's becoming very popular, and we do it a lot in London here. So one question for you, please. So the simulator would make trainees better at the simulator. What is the evidence, that it will make them better in theaters? Because that's the main concern that we have as trainers as well as trainees might be having.
Yeah, so I think simulations, sometimes we only use simulations when there's some constraint, when we not having the real patients a lot available. For example, today I was teaching some medical student. I was just doing the very traditional type of bedside teaching, and then bringing them just next to the patients and discuss with the patient and take the history taking and also physical examinations. I think in our current settings, these are still the foundation and the core value of how we treat our patients, because we still, I agree with it's that we have to, the AI agents maybe help us to provide lots of basic knowledge to our patients, but what we can do better than the AI in the current setting is still the human touch. It's our human interaction and how we explain the knowledge in our human language to our patients, and how we care for them in all those like physical touching and also communication. So I think these are some of the core value that we would like to bring to our student, and these are something that I think is not totally replaceable by an AI or simulation. But of course, you can some more adjuncts or some other non-core parts. I think we can use simulation to solve our problem. Yeah.
Thank you very much. Thank you. We're not going to take any more questions in that talk. To our final speaker is Dr. Ana Serrano-Ardila from Mexico. She's going to talk to us about digital dilemmas, ethics of AI in healthcare, which is a very important topic. Thank you. Up to you, Ana.
You need to unmute yourself.
You're muted.
I'm sorry. I was saying that I was very happy to see again Professor Imam, which I saw him and met him last year in SICOT dinner. And I'm very happy and pleased to be here with you. So I'm here in Mexico City, and I'm going to skip some of the concepts because my colleagues have already talked about them. But the beauty of this is that every single lecture that you made, they all talked about ethical use. And this is something that we need to address constantly. So I'm not going to talk about the operational definitions, but we already know what are the terms that are very specifically when we talk about AI. The current uses in orthopedics and in all healthcare system is, of course, imaging, about fracture detection and how can we speed up these processes, how can we grade OA or even triage the MRI. Of course, the other doctors talk about the clinical workflow and how can we optimize our daily activities in the clinic, surgical planning and research. So before using any of these AI tools, we need to have an ethical framework in which we need to ask the following questions. The first one is it safe for my patients, or does it cause any indirect or direct harm? Is it fair? Does it perform in the same way from a very diverse patient populations? Is the data handled with securely in a compliance it based on the local regulations. Who's going to be accountable for anything that may happen with the use of this data? And obviously we need to, and you have been telling this all the way, how human supervision is always needed. So I'm going to talk about a few cases that have been in real life. For instance, the case of a bias. What happened here? This is an article that was published in, I think, 2019. And the thing is, there was a health algorithm that was used for healthcare spending as a proxy to know how sick a patient was, but assuming that the sicker the patient, they cost more. But the assumption was an error because for Black patients, they historically had received less care due to systemic barriers that I'm not going to talk here. But the thing is that the proxy was having the good algorithm with a bias. So it resulted in an inequity in case of patients in diverse populations. So this was an article that was published, and the AI, of course, is very useful, but we need to address the fact that if there is a hidden bias, it will scale in a lot of patients. That's the case number one. The next one is there was an IBM Watson tool that was published and used for oncology. So they were saying, and they marketed as a very personalized recommendation for cancer treatment. And many hospitals pay a lot of money because of the prestige of the IBM. But then everything was good on paper, but not when it was applied in a real world. What happened here? It was very trained with a small set of patients based on a small set of patients in a single cancer center in New York City. But then it wasn't applicable for all population in any other center cases around the world. So what happened here? The overtrust is an error that we may fall where we see things very beautifully settle in the AI world. So overtrust is a thing that may impair us for basing our thoughts in our own training and experience, and of course, external validation. This type of tool wasn't validated for many population that, as diverse as medicine is. There's another case in which there was a model that was implemented in several hospitals to predict earlier if a patient was having a sepsis. But again, the results were very disappointing because they had two scenarios. The first one, there was a very low sensitivity for sepsis, but also it triggered many false alarms. So then healthcare professionals weren't attending the alarms that, like the cry wolf story. If you are having a lot of alarms, that healthcare professionals are not going to respond to that alarm. So what is applicable for us as orthopedic surgeons, that you can have technical performance and clinical utility, but there are different questions. And even if you have 80% accuracy on paper, if that doesn't show in practice, it is going to harm patients. Then the other case is what we have been talking about this morning, and it is how we use on clinical practice our generative AI. We do it for drafting notes, summarizing research or guidelines, building presentation, as many of us have done today, creating instruction, as the doctor told us about the bot in Telegram, and organizing or structuring research idea. And that is amazing. That's something that this generation can get used to. But remember that these tools can hallucinate references. This is a screenshot from the New York Times. It can make up many of the references or it can oversimplify many concepts that in medicine are very complex. Medicine patients' cases can have a lot of exceptions, contraindications. I mean, this is something that we need to address because it is not that simple or that difficult, but we need to have human criteria. And of course, we need to protect our patients' data. This is something that if we don't control from now, it is going to be a real problem for many of our patients. So what are the practical rules that we need? And this is maybe something that I'm going to repeat myself because some of you have already mentioned it. Use the AI as an assistant of a judgment, but do not replace it. You are the one who's thinking. Verify anything that needs to be there with the information patient because everything needs to be corroborated. Do not trust the most beautiful reference. You need to know for a fact that this is real. Be cautious with the patient data. Ask what trained the tool. This is very important because there are many examples of AI tools right now, but you need to know for a fact that this is well done and well designed. And of course, we need to have some type of resource and validation. You can disclose, and that's not a sin, to say that you use AI as a contribution. It depends on many journals. There are some strict baselines on whether you can use AI or not, but if you disclose it, there's no sin in that. So for the take-home messages, the AI is a blast, I think that, and it can make your life easier and better, but it also can scale error and inequity. So please be aware of that. And ethical use means that we as surgeons can hold accountable of our decisions. So this is an invitation for everyone. So let's adopt AI with the same rigor that we would do that in any other intervention in orthopedic surgery. Thank you very much for your attention.
That's great. So you guys have any questions? Please feel free to message the moderator. So if there are no further questions, I want to ask the panel, where do they think that we will be a year from today if we were having this very exact webinar, starting with Anna and then Khaled and Mo? I think you guys are still here.
Thank you, Suresh. I think that the legal issues are going to be in our door. So we are going to be disclosing as the same thing that we do on any lecture, like I don't have anything to disclose, the same, but with the AI use.
I think
What do you think,
this talk, not next year, but even in few months, I think it will be totally different because things are changing very fast. Every now and then every couple of weeks, we get a new large language model with new capabilities and new abilities. So it's really very murky and unpredictable. That's one thing. But on the other hand, I agree with Anna about the issues of the medical legal responsibilities and patient privacy. Still, it's very unclear because we're still waiting for the governments and the societies to put some rules and principles. And I think that's one of the great tasks that the AI and digital committee in SICOT took, that putting some rules. So in the future, that will be a great base to build on for the future of use of AI, not only in orthopedics. I would expect it will be also used by many other subspecialties.
I agree, and I think also,
Yeah,
yes, I totally agree. And Anna, Sorry, Amanda, go ahead.
I totally agree. And I think next time we'll also be talking about the expansion in the infrastructure, because one of the great limitations we have now, especially in the UK, is the infrastructure in the NHS allowing us to utilize all these wonderful solutions. The regulation is conservative, but it protects patients and it also protects us, given that so far the legal responsibility still falls on the clinician completely. So cautious optimism is not a bad thing at this point until we understand it better, given the fact that also we're not always the ones that buy the software. So you don't get the luxury of choosing which one you actually believe works better and you're willing to stick your name behind it as a clinician. Furthermore, I think there will be a lot more collaborations with clinicians. So a lot of the original software was developed independent of clinical input and then offered to us to try to improve on. Whereas now we work a little bit more collaboratively. We have channels and pathways to enable us to do that. So it will be more relevant and more accurate, and I think also more useful for us. If someone gives you a solution that you don't have a problem, you didn't think there was a problem in the first place, you're less likely to integrate.
Yes, and Amanda, we have a common quote in orthopedics. You being a radiologist might not know it. If it's not broken, why fix it? That's another thing.
Exactly.
Yes. And that's another issue there. And I agree, definitely. And Anna, thank you for that. And also infrastructure is huge. Resources is a big issue for every AI project, and like energy, water, and all that stuff. And you can see actually globally, this is a big issue which is happening now. And I'm in a smart health center now it's all surrounded by technology hub, and I was disconnected from the internet briefly for a few minutes. So it's not even the GPUs and how quick it is, even a simple Wi-Fi might let you down. So it was actually a great webinar, and thank you everyone for that. Anna, thank you for the lovely talk. Amanda, Suresh, Khaled, Lawrence, and everyone involved. It was a pleasure to be part of it, and I've learned a lot myself. Any final comments, Suresh, or anyone else?
No, wonderful to have everyone. Let's definitely do this again. And thank you all, the audience, for participating. Good evening and good afternoon.
Thank you. Bye-bye.